rate, rhythm, and access. The rate's looking fast. It looks like about like 180 maybe.
So I would just, in this case, since it's so kind of irregular, I would just count the whole thing.
Okay. So 1, 2, 3, 4, 5, 6. There's about 30 on here. Times 6, right? 180. Mm-hmm. Okay. So rate's about 100.
Divide that by 5. No, I'm kidding.
And I don't see any P waves. So, and it's very irregular. I would call this AFib with RVR at 180. Looking at the axis. It's down in 1, up in AVF, so right axis. Deviation. And then looking for ST elevations and depressions.
Wait, did you go through, did you go through, once you're at axis, then you go to there? V1, right?
To V1. Oh, right. So looking for a bundle branch. And I do see bunny ears, it looks like, in V1.
Mm-hmm. It's upward, it's an upward deflection, right?
Upward.
Yeah.
So right bundle branch block.
Yeah. So right axis, right bundle.
Mm-hmm. So, and that would be consistent what we would expect. And then looking at SD elevations and depressions, it's really hard to tell the isoelectric line here. Doesn't look like anything in 1, maybe some depression here in 2. As well as...
Yeah, there are some messy depressions, right?
Oh
okay.
yeah, depression in V5.
Okay.
V6.
Okay, so what do you think is going on?
Atrial fibrillation with RVR, and definitely some ischemia throughout.
Mm-hmm.
Which, I mean, we would expect with AFib this rapid. The heart doesn't really have a whole lot of time to fill and effectively pump blood out to the body. Yeah, is there...
So here you see there are these delta waves, right?
Oh, right.
It's classic delta waves.
Okay.
So you can see it here, right? I mean, pretty much everywhere.
Mm-hmm.
And in the setting of -1L, delta waves that are negative in 1 and L, and positive 2, 3, and F, V5, V6, and negative in V6, that means what? That's a lateral tract. So it's WPW with a lateral tract. So that means left atrial, WPW, which is, one of the easier ones to ablate. So typically, if you saw this person in the ER, what would you do, James?
I mean,
how much diltiazem do you want to give him? We said AFib, all right, first drug in the ER is usually diltiazem. How much would you give? You remember what we said the other day?
1.5, I thought.
it was 1 mg per kg?
No, it's 10 milligrams bolus, and then 10 milligrams IV an hour, and you can go up to 20 an hour. So 10 bolus.
10 bolus.
Right, so you give him 10 milligrams of diltiazem, and now he goes into VF and dies, right? Why? Dr. Ben Zur said give diltiazem for AFib.
Because we don't want to give diltiazem.
You give diltiazem and AFib except in WPW, because in WPW, if you give diltiazem or a beta blocker, then what's going to happen? So you're going to block the AV node more, and then more, stuff is going to go through. Well, this is not reentry. There's no reentry. This is the atrium is fibrillating. You have 2 pathways, one going down the AV node, and one going down the Kent bundle. So you're preferentially going down the Kent bundle. So instead of having a rate of 180, you'll have a rate of 300 or whatever, because you block the AV node.
Do you prosanamide and stuff?
Okay.
Procainamide, yeah. Persanthia,
Persanthia.
persanthia.
I was thinking my
After all your
That's good.
great pronunciations
Protein
in the
For
video.
the AFib,
Yeah.
Is
So-
the absence of delta waves enough to say that there isn't Kent pathway being used in
It's
AFib?
okay. What?
Is absence of delta waves enough to say that the AFib is inducing the bundle Kent pathway? Or how do you?
Yeah, if they're negative, you want to pause it?